great honor for me to introduce Professor Jamal Fikri. Fikri is President of Moroccan College of Fertility, Head of Postgraduate Degree on Reproductive Medicine, ART, and Minimally Invasive Surgery. And his topic is Submucosal Myoma and Fertility, to remove or not to remove. So we had a nice talk in area of ultrasound, and now we are going to kingdom of ART and hysteroscopy. Please.
Thank you, dear Shahrazad. Thank you, my friends, for kind invitation. I have 10 minutes to talk about a conflicting topic, and I go straight to the point, and the QA session we can develop more about that. Fibroid or benign tumor mostly. Malignancy is very rare. The prevalence increase with increasing age, and abnormal uterine bleeding is the most important symptom, but also fertility problems. And roughly, approximately 10% of fibroid or submucosal, which is the topic of today. Their impact on reproductive life of women concerning spontaneous pregnancy is really unknown. You have in the literature a wide range of spontaneous pregnancy, no matter the fibroid distort or not the uterine cavity. And after that comes this magnific classification of FIGO fibroids, type 0, type 1, or type 2, or at the first considered at the submucosal one, and the others intramural. And when we see the evidence in the literature about fibroids, we see that we have only one RCT from 2006 from Cassini reporting on treatment of fibroids. And this study reported a significant improvement in pregnancy rates when we remove those fibroids, but when assessed by American Society of Reproductive Medicine and Cochrane Review, this study was not reporting on significant results, so conflicting result. But the negative impact on the reproductive outcomes on fertility treatments is clearly demonstrated, showing that there is a significant reduction on reproductive outcomes, spontaneous and also in case of ART. But not on preterm birth. And they concluded that this impact is proved, and that we can have some benefit from the removal of such fibroid, hysteroscopic removal, with an improvement in pregnancy rate compared with patients with in situ myoma. And after removing this fibroid, there was no significant difference between patients with myoma and with no myoma, and many retrospective studies reported similar results. And the statement of the American Society of Reproductive Medicine concerning even asymptomatic myoma is, it is fair evidence that there is fair evidence that hysteroscopic myomectomy for such submucosal fibroid improves clinical pregnancy rate with grade B evidence. So no debate about 0, 1, and 2 fibroid, group 2 fibroid. The problem comes when we go over that and we think about type 3 fibroid, which is in the updated classification of FIGO, become fibroid is a hybrid fibroid because it touches the endometrium and particularly the junction zone. So this fibroid could be considered as impacting the similar manner the reproductive life of women. And this impact was demonstrated in this systematic review and meta-analysis, very recent, 2023, more than 1,000 patients. And in this woman with myoma compared with control, the live birth rate was significantly lowered and decreased in this group of patients, and the decrease is greater when you have numerous fibroid or voluminous fibroid. And this effect also was assessed in another study to try to find the cutoff in which, from which you have an impact on reproductive outcomes, and it seems that from 2 centimeters and more, this negative impact is demonstrated. This impact is probably related to what all we know about fibroids, but what is specific to type 3 fibroids or all fibroids impacting the endometrium is the uterine contractility and impaired endometrial receptivity, and I will try to develop a little bit about that because the similarity between type 3 and other submucous fibroid is that impacting junction zone in which you have the trigger for uterine contractility, and this Japanese study from more than 10 years ago published by Yoshino demonstrated clearly that in patients when they use cine MRI with more 2 contraction within 3 minutes, if you have more, you're in hypercontractile group, and this hypercontractile group has no spontaneous pregnancy. When they operated the patient, 2 years later, they published their results, and among 15 patients operated with hyperistaltis, they demonstrated that this hyperistaltis disappeared in all patients except one, and the live birth rate was 40%, exactly similar to patients with no high contractility, and most of the pregnancies was spontaneous. And this publication by Dolomans explain how we have the second impact on reproduction. It is impacting endometrial receptivity exactly like other pathologies impacting the junction zone. We see yesterday about adenomyosis. It could be exactly the same for fibroids. And this negative impact has been published from many years ago. You have altered decidualization. The markers of endometrial receptivity are dysregulated, particularly the production of TGF-beta 3 in excess could impact all other features included in this endometrial receptivity, hoxaten, beta-3 integrin, leaf, and so on. So let's return to the Cassini study, in which they have published increasing results when operating submucosal fibroid, and at this time, FIGO classification was not available. They have reported a great increase when they operated intramural with impacting the submucosal. And this is the case for junction zone. And this impact of type 3 fibroid have been described and reported. And also, the feasibility of the surgery also was demonstrated by this group with no complication reported in this series, and they have improved. It is a study before-after, so we know all the bias related to that. But they reported an increase in live birth rate and no incident, no accident in this surgery. And I think that the safety is to have always in mind the role of the pseudocapsule in this surgery and all the other surgery. And some leading experts like Kit Isaacson here present are okay for treating type 3 fibroid with hysteroscopic removal, and the pseudocapsule, in my opinion, is a key point for that. And we have now literature coming from some groups. They have operated type 3 fibroid, retrospective study as always in the beginning, and they have reported an important results when comparing type 3 fibroid left in situ to the control group, tubal infertility. They have significantly lower cumulative live birth rate, and in the group operated for type 3 fibroid, the result in terms of cumulative live birth rate was similar to the controls tubal surgery. This is a demonstration of how we can deal with this pseudocapsule, which is, in my opinion, a key point of this surgery. This is fundal type 3 fibroid. Just remove a little part to open the uterine wall. Location. The first step before cutting anything is to search for this pseudocapsule. You can enter it by using the hydrodissection and also mechanical use of your device. You enter the pseudocavity, the pseudocapsule, you detach progressively the connective tissue, and you do as deep as you can before any cut. And when you encounter some specific or some significant vessel, you can apply a little bite of cautery to prevent any bleeding when you start cutting. And with this way, you have always a clear view on the pseudocapsule, which is the border to respect when you want to do safe surgery. And also to have a good healing of that myomectomy, because this good healing have an impact on the obstetrical outcome and so on. So that's my opinion about that. It is a conflicting topic, I know. The evidence is scarce, but as always, we start like this and improve our skills to know if we can do that safely. If there are other methods to treat it, I mean medical therapy, possibly, and perhaps ultrasound or whatever you want. Thank you, and I would like to talk about our congress we are organizing in Marrakesh from 7 to 9 November. It's a World Congress on IVF with the International Society of IVF, and Morocco is organizing this year, so I hope you can be with us. Marrakesh is exotic by day and very exciting by night. So come.
Thank you. Thank you very much.